Hi, everybody. Those of you who are just coming online, we're just waiting for this to be broadcast out across the network. So just wait a few seconds for people to join. Just make yourself comfortable. Always a bit of a delay. Okay, we might get started. So hello, everybody. Thank you all for joining us for this webinar, which is part of a series of presentations that will be delivered on applying evidence in practice as part of the Comorbidity Project, which is being funded by the Australian Government Department of Health. My name is Christina Morell. I am a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. I have the very great pleasure of facilitating this webinar, which is going to be presented by Dr Suzie Hudson. Before we get started, I'd just like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise, of course, that we are meeting across Australia today. The traditional owners of the lands that I currently am on are the Gadigal and Wangal people of the Eora Nation, but I'd also like to pay my respects to other traditional owners of the lands across Australia for everybody else who's here. I'd also like to recognise and acknowledge the many people with lived experience of mental illness and substance use, as well as their families and carers, many of whom have generously contributed to the development of the comorbidity guidelines and associated resources. Everybody here is probably really familiar with how to use Zoom by now, but just to quickly go over a few things before we get into it, just to let you know that everybody who's looking at this today is in listen-only mode, so we can't see or hear you. So just to draw your attention to the Q&A and chat buttons on your screen, please feel free to click on those and type in any comments or questions that you have during the presentation. We will have a few minutes at the end of Suzie's talk for discussion and we'll go through some of those. If you have any technical issues during the webinar, you can contact Zoom support or you can access the recording of the webinar, which we'll be making available, as well as PDF handouts of the slides from today. They'll be available to download from the website on your screen there. We also have an exciting series of webinars over the next few months. Today's will be focusing on implementing evidence-based practice, but you can find out more and register for our upcoming webinars at our website, which I've posted on screen. And now to get started, it's my very great pleasure to introduce Dr. Suzie Hudson, who is the Clinical Director of the Network of Alcohol and Other Drug Agencies. Suzie is an accredited mental health social worker with over 20 years of clinical experience in the fields of substance misuse, mental health, forensics, research and evaluation. We've been working with Suzie and NADA for many years, and I'm so very glad that she's able to be here today. And I think that she even has a few surprise guests who are going to share their knowledge and expertise about implementing evidence-based practice. So without me going on too long, I will hand over to Suzie to get started. Thank you, Suzie.
Thanks, Chris, and welcome everybody. Thank you for joining me. I am Dr. Suzie Hudson and I'm the Clinical Director at NADA, the Network of Alcohol and Other Drugs Agencies. I'd like to start by acknowledging the traditional owners on the land on which we're all meeting today. I'm on Gadigal land today, and I'd like to pay my respects to the Gadigal people of the Eora Nation as the traditional custodians of the land on which the NADA office stands. We extend this acknowledgement to all Aboriginal and Torres Strait Islander people across Australia and pay our respects to elders past, present and future. So today we are going to be chatting away about implementing evidence-based practices and what AOD, so alcohol and other drug managers and workers, need to know. So the key learning objectives that I'll run through today are to describe the evidence-based practices that are effective for working alongside people with co-occurring alcohol and other drug and mental health conditions, to really look at identifying some of the key stages to implementation in an organisation of these types of practices, and to also understand how effective implementation works in practice through a couple of case studies. And I've got some guest speakers with us today, which I'll be very excited to introduce to you very shortly. So let's start with evidence-based practices. And I suppose one of the things I really want to emphasise today is who are you seeing currently at your services? And I think the reality is you'll find that the majority of people coming through your doors or reaching out for support are indeed experiencing, among other issues, some concerns around their alcohol and other drug use, and potentially concerns around their mental health. So we know that people come with a multitude of needs that might be needing addressing, but we're also aware that there's lots of resilience, and that those who are reaching out for support have some great supports that we can tap into and much to contribute to the sector. I want to touch briefly too on the power of language and the importance of respect. We know that language has a way of lifting people up or keeping them down, and it is our role that we do address the stigma experienced by people who use alcohol and other drugs and who may be experiencing issues related to their mental health. We need to be aware of it, to be able to address it, and to really engage people that shines a light on the importance of their identity, their culture, and the importance of respecting them in the context of treatment. We really need to be thinking at all times about the power of inclusion and collaboration with our clients and their families, networks and communities. They're all part of the treatment process and can really cement treatment outcomes and certainly ensure that they are sustainable beyond their time with us. So what is evidence-based practice? And really what's so exciting about it is that it is a combination of things. It absolutely attends to research information, what we've actually learned from that scientific evidence where things have been tested and tried. We've got outcomes. We're able to see the types of people who are entering into a particular program and whether that program might be effective. We need to look at it with a discerning eye, and I'll come to that briefly in a moment. The other element of evidence-based practice is that clinical experience or expertise. So that is your experience if you're a worker in the field. What is it you're bringing to the picture? And the third and most important element is that experience of the person who's reaching out or accessing support or treatment. So the client or patient, their caregivers or supports, and what their perspectives are. The most important thing to recall or remember about evidence-based practice is that it's this combination of three very important elements, and I'll go through those now. So if we're talking about the people and what works and what they tell us works, it's really about ensuring that the questions we ask as part of an intake, orientation or assessment process are as inclusive as possible, that they're able to share their identity and the many facets of their lives that we're able to really harness to ensure that treatment's very effective, holistic, and really responds to that person's needs. We want to know what we can grow in terms of their potential supports, and certainly we want to be able to unearth their interests and strengths. And what about the research? Well, what we know works when we're working alongside people who may be experiencing co-occurring issues is that a genuine therapeutic alliance is important. So that is the relationship between you and the person that you're supporting, and perhaps those who may well be supporting them beyond their treatment. We know that motivational interviewing works, and there's some excellent e-learning resources and certainly tips and tricks within the comorbidity guidelines that really explore motivational interviewing. But we know that it's very effective for both creating and engaging people in terms of motivations for change as regard their alcohol and other drug use, whatever their goals may be, whether it's to reduce harm associated with their use all the way through to abstinence, and certainly too in relation to mental health issues. Cognitive behavioural and dialectical behavioural therapies are proven. We know that the evidence can tell us this, but it's useful to also keep in mind the types of studies that have yielded these important results, and sometimes to ensure that whatever practice that we're implementing, it's actually often comes back to that therapeutic alliance. Psychosocial groups are very effective and can also really support individualised treatment. And we know that for some mental health conditions, pharmacological support and indeed also substitution support or pharmacotherapy in the case of alcohol and drug use is very effective, but always in combination with that psychosocial intervention. And all of these types of interventions are well researched. We've got good evidence to suggest that they're effective. And what about you? What about your experience? Certainly having the skills, knowledge and attributes are important for the work that we do. And certainly we can ensure that we're getting those needs met through our professional development, ensuring that we are engaged in some level of clinical supervision and that we maintain that curiosity for really understanding and wanting to see where the person is when they come in to see us, where they're at, and that they themselves are the experts on their own lives. Certainly working within our own capacity. And I suppose a really important tip is that we do build those relationships with others who have a specialty. And what I mean by that is that we should always be working to build good connections within the mental health and other specialist fraternities so that when we do need assistance or we need to escalate a certain situation, perhaps the person we're supporting needs other specialist help, they might need a particular kind of assessment or perhaps some medical intervention, that we know what those pathways are and we really attended to that. Certainly reading the comorbidity guidelines and doing the accompanying e-learning can really grow your confidence in this area around supporting at the same time the mental health and alcohol and other drug needs of the people that you're there to serve. We also know that feedback is critical, and that can come from both setting patterns with our clients that are giving us feedback about how the treatment is working for them. It may be also about the therapeutic alliance. So how's that relationship going from their perspective? We want to ask people about their treatment experience, we want to hear it, and we want to respond. We want to review a person's plans regularly to really connect with them and to grow those ongoing supports so that we know that whatever treatment we're providing will end at some point, perhaps an intensive part of the treatment, and what is it that that person will do beyond what we're providing. So that really sustained support that might be there. And that's where we need to be inclusive of families, other significant people in that person's life, networks or communities. And where there aren't those supports, what can we do to help to grow those? And certainly, identifying staff learning. So what is it that they might need to really encourage them to engage well with every client, however they come to see us, and that they're able to provide effective and evidence-based treatment. And so now it's time to meet my guests. What will really help us cement some of what we've been talking here about evidence-based practice in the mental health and drug and alcohol sectors is hearing from those that are actually providing these services. And I'd like you to meet them now. So joining me now is Dylan Clay, and he is the Program Manager of Speak Out Dual Diagnosis Program. He works there at Weave Community and Family Services. And I'd like to introduce him to you now and to say, hi, Dylan, how are you today?
Hi, Suzie, I'm good, thank you. Thank you so much for having me, I really appreciate it.
So could you tell us, first of all, Dylan, a little bit about your work at Weave?
Yeah, sure. So we captured it pretty well in the brief intro there. I'm the program manager for the what we call the Speak Out Dual Diagnosis team at Weave. So essentially our team is positioned in the org to sort of deliver support, holistic therapeutic case management and counselling, amongst other activities, to 12 to 28-year-olds with co-occurring mental health and drug and alcohol use. And we sort of sit within the organisation that offers a number of other small sort of targeted programs and often work in collaboration with those other programs, including, say, the Creating Futures program that is a youth justice program, so sort of post-release support and other things, and there's a lot of kind of crossover between all that work. But yeah, we're particularly focused on that young people's support for co-occurring AOD and mental health.
Yeah, and so Dylan, for some workers and managers, thinking about how you integrate your work and make it seamless for the client, the person who's coming to reach out for your support, what does a dual diagnosis service actually look like in practice? So in your case, for Speak Out, can you just take us through a little bit about how you work and what that looks like?
Yeah, of course. Look, really good question. I think for us, we are certainly in-house very passionate about that sort of disentanglement of the lines between what constitutes a mental health service or what constitutes an alcohol and drug treatment service. For us, the way that it looks is we really do believe we're an integrated service. It's not just the fact that we have these small little teams within the org, but even just within our team, the core function is a casework counselling position, which is a dual function role that is sort of positioned to offer holistic case management. I referenced therapeutic case management, which is often what we call it, and also counselling, whether that be AOD counselling or mental health support. And what is so, I think, important for us in considering the service delivery is that people are often coming to support for one thing or for another thing, but rather than seeing them in isolation, it's sort of taking the person, meeting them as they are, and really being guided by them in what support looks like. So if they're identifying to you as the practitioner, as the professional, that they are particularly interested in support in this one area, our belief is, as a sort of a strong integrated offering, that you kind of are holistically supporting that person through being led by them in what are the most important areas of consideration. So, again, with that dual function role of the casework counsellor, we often find ourselves, we have fantastic counsellors that we work with at Speak Out, and I'm really proud of the team. But we have these sort of skilled counsellors that will often find themselves doing case management, heading down to Centrelink, heading down Services New South Wales, getting a driver's license, but that whole time, that process about discussion, integrating concepts of harm minimisation, integrating those higher level conversations about their mental health experiences through that's sort of that therapeutic case management that we reference, and really allowing somebody to tell us, being truly client-led, and let them tell us what it is that they really require support with them. And I think that sort of sums up integrated support and our approach to co-occurring stuff, yeah.
Yeah, and so in that space, are you finding then that the approaches that you have and your clinicians have, whether they're, specifically addressing some of those experiences of perhaps mental health distress, say, the approaches that they implement are just as helpful, whether they're addressing the mental health experience or the drug and alcohol, or the combination of the both, that they're able to, I suppose, be clear about what approaches they're applying for that individual and making sure that's tailored to their need. Do you find that their skill sets are able to respond equally to both the mental health and the drug and alcohol side of things?
Yeah, I absolutely do. I think one of the core tenets of working in sort of integrated support for co-occurring mental health and alcohol and drug use is that recognition that it is a blurry line, that you'll hear things like chicken and egg type arguments around which is causation, correlation, all these sorts of conversations, right? But the core tenets of it is that they are co-occurring, that there is often underlying trauma, there is often a number of things that are playing into that, and a skilled practitioner in our experience may be doing quite a targeted mental health intervention or providing really long-term sort of holistic mental health care. At the same time, maybe not explicitly targeting a particular alcohol or drug use or misuse. However, we see more times than not changes in behaviour as people become more comfortable with the mental health experiences that they're having, or feel like they are making progress with the mental health experiences that they're having. And I think that the same is also true in reverse, right? If you're working in alcohol and drugs, often there is just explicitly you are working in mental health a lot of the time, especially at the pointy end.
Yeah.
You know, it's one thing to say someone's using a little bit, but if you're supporting someone who's really pursuing alcohol and drugs in a big way, you are working in mental health. That's the reality of it. So I think that they function in that same example I just gave, functions really in both directions. If you are making those interventions and having those conversations about harm minimization and weaving in sort of the mental health side that comes along with that and addressing alcohol and drug use, then you're often, again, sort of working in both areas at the same time.
And I know that some of the programmatic stuff you do, say, for example, doing Mad Pride, that's specifically about young people talking through their lived experiences. Can you tell us a bit about some of the programs that you do and how they start to address, I suppose, some of the issues that people might present with?
Yeah, I mean, Mad Pride is a good example. We're very lucky in Speak Out. You know, we talk about it a lot. We're sort of in that privileged position that we have 2 staff in our team that are in a project work function, which means we get to do this really amazing sort of creative work. A lot of it sort of takes the shape of creative advocacy or trying to provide platform and voice for young people with co-occurring AOD and mental health experience, or it also could just be meaningful ways to engage people differently. So, you know, Mad Pride is an event for anybody, I guess, listening, watching, that isn't aware of the event that we run. It sort of started, I think it was a Canadian event, actually, if I'm correct in thinking that it was a Canadian initiative out of BC or somewhere, where Mad Pride is essentially, the reverse is the sentence, it's pride in being mad, I guess was their original concept. But it's truly a celebration of mental health and the diversity of our experiences, and really trying to destigmatize what it is to live with mental health and to have this sort of just eclectic, diverse world that we live in, and just normalizing that and saying, hey, yeah, this is me, and this is how I am and how I live in the world, and providing platform for young people to come forward and engage with it how they see fit. So we'll run a panel, a youth expert panel, we call that, which is sort of providing platform for people with lived experience, young people with lived experience, to talk to the sector. So professionals, practitioners in the space who may be listening to this now. We also run like a creative event where it's like music and poetry and spoken word and rap and singer-songwriters and whatever else. And again, it's just that celebration of sort of, this is who I am. But further than Mad Pride, I think there's an overarching sort of as an overarching approach, it's a real commitment to responsivity and being truly client-led. So we understand that not every person is going to want, in the same way that I've referenced trying to disentangle the lines between mental health and alcohol and drug support, it's just an understanding or a recognition maybe that not everybody is going to need the same kind of support to tackle what we may see as the same issues, right? So we've got people that are using alcohol and drugs and having self-identified or clinically diagnosed mental health experiences. However, those 2 people, 3 people, 150 people are not going to need exactly the same sort of support. Particularly when you're working with young people who are finding their feet in so many other ways at the same time, are so amazing and so resilient and so creative and engaged in ways of solving problems that come up. We try our best at all times to listen to that and say, what's going to work, you know? And we've got really great examples recently of, we were running at Weave, a young men's group, which was made up entirely of Aboriginal young men that were sort of spending time together in the community and sort of grew up together, but sort of one of those moments in this work where everything lined up perfectly to strike while the iron was hot, and created this young men's group with really strong cultural leaders and elders from the Aboriginal community in the southeastern beaches. And just the work has been amazing. And that came from them saying, there's a gap here for us. You guys are amazing, but there needs to be more self-determination. There needs to be us. We need to be skilled up with the language and the concepts to support each other. And it's been truly incredible to watch, and that now runs totally autonomously. And they're getting up, they're doing sunrise ceremonies together at Malabar and Buckaroo's beaches, and it's truly incredible. And just little opportunities like that where you can hear from your client group what it is that they require. They'll tell you what it is that needs to be done, and we're privileged in this team at least to be able to often respond to it in creative and interesting ways.
That's fantastic, and leads me quite neatly onto a bit of an implementation process that's going on now, as I understand at WEAVE, which is to implement an Aboriginal healing framework. If we're talking a little bit about implementation of, that whilst WEAVE has always been Aboriginal community oriented and certainly engaging the community, what does it look like from a worker point of view to be implementing this healing framework, or at least receiving on the receiving end of this change?
Yeah, the Aboriginal healing framework is a really incredible piece of work. It's obviously being led by my colleagues in our Aboriginal staff group. And, it's a privilege to work and learn alongside such a well-informed and kind of connected Aboriginal staffing group at WEAVE, and there is a line with the Aboriginal Healing Framework that I will do my best to represent it to the level that I can, but obviously it's not my work, and I'm not one of the Aboriginal staff, so with that in mind I'll continue. But the Aboriginal Healing Framework essentially sits above everything at WEAVE now. So although we are this integrated service in Speak Out, and we have all these small teams at WEAVE that do little bits and pieces of work, the Aboriginal Healing Framework is designed to sit above all of that. And we're talking about implementing something that kind of is a organisation holistic response to centering Aboriginal healing is, it sounds quite daunting, but I think what's been happening is we've been rolling out slowly. We have an Aboriginal support manager, we have an Aboriginal cultural lead who sits on the senior executive. We have I think it's 4 or 5 now Aboriginal board members, Aboriginal program managers, who have sort of just at every stage of the rollout targeted little areas of the organisation and brought them on the journey. Right. So starting back of house, starting with HR, with hiring processes, with job ads, with the ways that we deal with each other in the workplace, to the ways that we meet somebody when they walk in the door, working with intake to say how can we change our processes to make sure that there's true consideration for centering Aboriginal healing or making things culturally safe and acceptable in practice, then moving to the frontline teams and saying, okay, how can we have conversations with clients to center Aboriginal healing? And it's been really quite amazing to watch. And it, by no means is done, but I think what it points out to me is that if a diverse cross-section of an organisation, or say, let's, on a smaller level for some people watching, a team potentially, get behind something and are committed to seeing it roll out and committed to hold it and let it play out step by step and really get behind it and engage with it meaningfully, then you can see pretty amazing stuff. I've been impressed by this organisation so far in the rollout of the Aboriginal Healing Framework and the commitment of our wider teams to really engage. It's sort of only partially done at this point, but so far so good.
Yeah, that's amazing, Dylan. I mean, I think it really points to some of those key parts of implementation, which, as you say, is that commitment, is that it has to be organisational wide, and exactly as you say, it's that bringing people along on a journey. And you provided us with some really helpful ideas too, because what it talks to is how important that person's experience, and in this case, Aboriginal culture, how powerful that can be as a healing tool. And certainly as non-Aboriginal people, you and I, it's about how do we invite those who have those experiences and knowledge into the therapy, into the work that we're doing. And most importantly, have the client or the person reaching out support guide the treatment that they receive. And I suppose, therefore, you can't really get it wrong, can you? If you're really being led by them, you're able to bring those all those parts, provide very holistic care, which I suppose is at the key. And one of the key messages too, I suppose, of the co-occurring guidelines is really being led by the client, being sensitive to potential experiences of trauma, but most importantly, looking at options that are going to best suit where that person's at. And so, in sort of summing up Are there any particular little tips or things that you would leave if we're talking about working in that integrated, holistic way? Are there things that you want to leave the people joining us today with in terms of, say, a couple of top tips from you?
Oh gosh, it's hard here not to jump on the high horse. No, I'm kidding. Look, I think for me, and again, like I love the team that we have here in Speak Out at Weave, and I've worked in alcohol and drugs pretty much for a good few years now as a key focus of the work that I've been doing. And I think the real universal truth is something I said before. If you're working with people that are using alcohol and drugs in what you would categorize to be a pretty serious way, you are working in mental health as well. And, you know, I think if there is a strong considered push by our sector and by the practitioners to just really commit to disentangling those lines, we'll see some really serious developments in the way that people are met by our profession, by our sector, by support and clinical care more generally. You know, sometimes I think it's easy to overcomplicate in some ways when we talk about these things. The guidelines are fantastic. It's really important to engage with material like that, but to almost strip it away to a more basic level, for me, if you even think about some of the basic stuff that we talk about, trauma-informed care and things like that, you know, choice and being person-centered and client-centered is really at the core of all of that. And it's so true of so many different parts of client-facing support work, that if you listen and respect people as the experts in their own in themselves and in their own recovery or their own journey, then you will get outcomes. I really believe that, and I think that would probably be the only little bit of I can't call it wisdom, I'm sorry.
I would call it wisdom, Dylan. That's great. Look, thanks so much for joining me today. I really appreciate it. Have a great rest of the day, and I hope to see you soon.
Yeah, thank you so much for having me. I really appreciate it.
Thanks.
Yes.
And joining me now is Danielle Breeze. She's the Service Manager of the Illawarra Treatment Service of Kadesh Rehabilitation Services. Welcome, Danielle, and thanks for your time today.
Thanks for having me.
Brilliant. I thought we could get started, Danielle, with perhaps, you know, Kadesh provides a number of different types of services in New South Wales, but they all have a dual diagnosis focus. So that is, you know, taking into account people who may be attending for both their mental health and alcohol and other drug needs. Can you tell us a bit about the approach and how you work there at Kadesh?
Sure thing. So as you mentioned, Susie, we are a dual diagnosis service provider. And what that looks like for us is we've got residential programs, we have day programs, we provide outpatient services as well. And we work out of the Illawarra, but also the Northern Beaches. So we do have two facilities. So the different types of models, I guess, we use for our intervention for those dual diagnosis purposes are things like DBT, CBT. We talk about different kind of psychoeducational groups that are relevant. We individualise counselling, case management. That's all supported as well by that kind of ongoing assessment of the clients. And as well as that, we're incorporating a lot of external service providers to really bulk up that service kind of transfer of care, that community practice, all wraparound support for that client. So that's kind of what we do in a nutshell. I mean, historically, we just focused on AOD, and that's what it was. But obviously, over time, we've started to see this emergence of, you know, clients who really need that extra help with their mental health as well. And so that's when we kind of incorporated local health districts and units to help us focus on the mental health aspect side of things.
Okay. So just with that, Danielle, sorry to interrupt, but I'm just curious about that particular aspect. So what you're sort of saying there is that you've got this holistic care and you've got programs that very specifically target both those mental health and drug and alcohol needs, but you've also explored some of those pathways, I suppose, into perhaps specific mental health treatment services as well?
Correct. So we work quite closely with a few different services in each area. So like I said, in the Illawarra, but also up Northern Beaches. And New South Wales as a whole. I mean, if we're talking about client-centered, we've got clients who come from everywhere, so we're really trying to engage ourselves in the community. But we also understand we are experts in an area, but we have to lean on other people as well for those strengths and supports, which is really important. And we can see that in the outcomes of the clients as well that we're working with.
Yeah, that's fantastic.
Yeah.
And so, with those practices that Kadesh has implemented, can you tell us a little bit about what some of the steps and activities that have been needed in order to implement that type of work that you do there?
Yeah, so I mean, since we kind of transitioned more to a dual diagnosis treatment provider and use that integrated approach in our care, we've really had to, well, first of all, it's been a bit of a lengthy transition. We're talking about kind of 4 to 5 years of working with a client-centered care model. But in order to do that, we have to have really good quality improvement processes in place. So really leaning a lot on our policies, our procedures, but also help from accrediting bodies and things like that, which as a manager has really helped me, I think, in implementing some of the improvements that clients come to me saying that they need, staff come to me saying that they need. So having that foundation there in continuous quality improvement really is kind of what the success and the outcomes is based on. So in terms of that implementation, you're talking about engaging the clients and the staff in feedback discussions, focus groups. You're talking about analysing the feedback, the development of working groups for the staff as well, so you've kind of got that buy-in from your staff that you're working with. But then, it kind of has to follow on from there. So you're talking about initial draft implementation of whatever improvement it is that you want to put in to your practice, which is, of course, evidence-based. This is what we're really going on, it's all through the co-occurring AOD guidelines that we talk about. And so once that draft has been implemented, it's talking then about looking over the data for it. What does it tell us? Where do we need to improve? Okay, we'll go back to the drawing board. We'll make some changes. We'll re-implement. We'll resurvey. We'll get some more feedback. And it's just this ongoing cycle that can take a while.
Yeah.
So with something simple that you want to implement, it could take up to a year before you're comfortable enough to know that it's working well, but that it's actually beneficial or it's actually not. So it's really about that commitment, I think, from the service and its governance amongst the service as well, to support what it is you're trying to do.
Yeah, and I find it's really interesting, isn't it, that you're having to think about both those, the different levels, I suppose. So the overall organisational, you're responding very much to what clients or people accessing the service are telling you, and as you say, looking at that data, but also bringing the staff along. I think that's quite an important one, isn't it? Do you know, as you said, you mentioned there a couple of things like, getting the staff together, reviewing things. Can you talk us through a little bit more just about that staff engagement side of things? Did you have staff that were perhaps saying to you, look, I think we're already doing it. What are we supposed to be doing more of? How do you engage the staff in terms of some of that change?
For sure. I mean, initially it's all about bringing the idea to the table and discussing it as a whole. So you want to kind of communicate it to everyone. So that transparency is so important.
No.
But yeah, you do get a lot of people who are kind of like, aren't we already doing that? And the reality is a lot of the time we are doing it, or we're doing a version of it, but because we haven't really embedded it in the treatment and it's not necessarily evidence-based at that point, there's not really a lot to qualify why you're doing it, and you want to be able to show good outcomes. So I think being transparent about it, bringing the staff along as a journey, but getting people excited about it is really important. And I suppose from my own experience, the way of doing that is you need to get the feedback, you need to be able to present results back, you need to be able to, I suppose, just encourage staff that what you're doing is the right thing, or if it's not, then we need to look at what is. And I find that a lot of staff who are kind of, on the journey that like I said, it could take months to implement something. It could be up to a year. but they like seeing the results. They like seeing that kind of ongoing progression. And then it becomes second nature, like everything else we do. But instead of we're already doing it, it's yes, we're already doing it, but now we have the qualification to do it, which leads to good outcomes, you know?
Sure.
So it gives a bit of, I think anyway, workplace satisfaction. I certainly see it in the team, and everyone starts talking the same language as well.
Yeah, that sounds really important. I suppose too, that idea, were you bringing the whole team together? Were you starting with splitting management and then the work staff, or were you bringing the whole team together all at the same time?
Yeah, it depends, I suppose. I mean, we have bi-monthly staff meetings, and you know, there's a lot of communication around agendas and what we want to talk about, or something that might have been picked up, or like I said, feedback from clients that gets brought up. Let's address it and have that follow through. Let's not be the people who just see a suggestion and put it in a folder and forget about it. Let's be the people who action it and give feedback to clients, staff, whomever it is. So it's about getting everyone together in a room. That goes from CEO to management to night shift workers.
Yeah.
It's really about including the entire team. And not only that, it's feeding it back to the clients as well. If whatever we're trying to implement is relevant to them and their care, then they should absolutely be a part of that. That is how you get them to own a little bit of that. Buy-in in their own treatment, you know, motivation as well. It's really, really important.
Yeah, that's great. So that's quite interesting, isn't it? I think maybe something that's developed over time is how important it is to keep those who are reaching out for treatment, so those clients that are in our treatment programs, involved with these change processes, because as you're sort of suggesting there, some of those ideas can come from them about what's best for their treatment. You're starting to see some themes. I'm also picking up there that importance of feedback. So whether that's directly to the client, but also to staff. And sometimes in a managerial position, you can forget that you know, the outcomes. That's something that staff need to be seeing, isn't it? So they can see whether the work they're doing is effective.
Absolutely, absolutely. Really, like I said, it just builds on that workplace satisfaction. And if you're working together as a big group in the beginning and then, you know, implementation occurs, you're talking about breaking things into little working groups, and you're using certain people's skills to jump in, get themselves involved in certain areas that they're interested in. We all know that when we're interested in something, it's a lot easier to do that.
Yes.
But from a management perspective, it's really important then for me to foster that working group, to give them enough time. It doesn't mean that, you know, you've got to get it done tomorrow or yesterday.
Yeah.
But it's being realistic. You've got a time frame. Let's follow it up. It doesn't have to be done, but just let's keep the ball rolling with it so we are progressing, that we can note where we're up to if there's any further developments needed. And it actually brings another part of work, I think, because of the environment we work in. A lot of the time we're face-to-face with clients and not necessarily looking at the evidence and the research behind what we do. Yes. And that ability to offer your staff, who are in lots of different positions, can really encourage them and get them on board with, like I said, those foundation quality improvement processes. It's got to be fed through the entire team, not just the person who's overlooking and overseeing it all. So, yeah.
And so I suppose in a nutshell, you talked there about how Kadesh is really trying to weave those processes in place. They're the clients that you're seeing. They're presenting with, you know, a multitude of potential things they want some support with, but certainly that mental health and drug and alcohol is front and centre. Just in summary, are there things that you would really like to leave the people that are viewing this today with, in terms of what you think are some of the key things and key important parts of that implementing a co-occurring or dual diagnosis service?
Yeah, I think a lot of the time, Suzie, that you can start work in an organisation and not really understand the organisation's vision or their strategies that they have in place to support the vision. And it's really similar to what I said at the beginning with that buy-in and how important it is. And there's lots of different ways to manage that with staff. But I think having that foundation knowledge around what it is you're trying to achieve with the demographic that you're working with, and again, the shared language in which you use, so that knowledge really is so important. And that's only the base level of, I guess, what I would like people to take away from it is you need to have that at the forefront to be able to kind of spread the word a little bit amongst the demographic of what it is you're trying to achieve. I think things like ongoing professional development and supervision and training is of utmost importance. I mean, we can only work within our capacity. So we talk about how we're dual diagnosis and we provide a certain level of client-centered care and we try and be flexible about that. But we're not experts in every area. We like to think we're experts in the things we know.
Yeah.
But we also need to be humble enough to lean on the people who are experts in their area too. So, for example, if we're shy on clinical expertise, then it's about me seeking out advice from a clinical psychologist to give some knowledge around some policies or some practices or debriefing about certain presentations. So that's really important as well. It really builds on that kind of toolkit you've got as a service and the strengths you can push forward with the staff as well. In terms of engaging the client, obviously that's very, very, very important, especially when we're talking about client-centered care.
Yeah.
The idea is that you are collaborating with that client and they're leaning on you for your clinical expertise to guide them. They need to be the owner of their treatment.
Yes.
But, you know, the guidelines themselves are simple. You know, that therapeutic alliance is so critical. It is essential in that client's outcomes and specific individual outcomes as well. So, yeah, it's that kind of... We talk a lot at Kadesh about our values and how our values need to align with the clients in some respect. And we liken it to a relationship. If the values don't align in a relationship, it doesn't work that well. And so we try and communicate with the clients in that same way. And we found through surveys and feedback with clients that they are coming back letting us know that we feel really involved in our own individual treatment. We feel like we're being treated like a human, not just a stat. And it's ongoing. It's such a positive piece of feedback for us to get to show that we're doing the right thing and how important that therapeutic alliance is and where we're coming from. And you know, it's really about, again, the transparency. It's transparency with clients, it's transparency with staff as well. It's how the clients become confident, they buy into their treatment, it's how staff buy into what they're doing in terms of facilitating treatment, things that they're providing. And again, just ultimately increases workplace satisfaction. So, yeah.
Thank you so much for your time today, Danielle. Really appreciate it. I hope you have a lovely rest of day and I hope to see you soon.
Yeah, sure thing, Susie. Thanks for having me.
So now that we've heard from our special guests, Dylan and Danielle, and we thank them very much again for their time, let's really try to pull together some of the threads that they've highlighted there. They certainly touched on a lot of those topics of what makes good evidence-based practice in terms of working alongside people who may be experiencing both mental health and drug and alcohol issues. But let's talk a little bit about implementation. And as a manager and a worker, these are all our responsibilities. So it might be that we start to think about what are the guiding principles when we're providing this support. And these are a bit of a summary of some of those that have come from the comorbidity guidelines and really try to pull together some of those common themes. Certainly it's about adopting a no wrong door policy. So it may well be that we might not be able to provide everything to all clients that come through our doors, but what are we able to link them up with? We might be the conduit through which there are other supports that they can access. So it might not be that we need to refer them on necessarily, but are there people that we can consult with to improve our practice? We might see a number of clients coming through the door, for example, who are experiencing particular particular issues around anxiety or sleep issues. So, is it possible then for us to grow our capacity in that area and respond? Really, that we're holistic and person-centred, and that's very much the ethos of both alcohol and the drug work and mental health work. Really recognising that you're actually working with these people right now, and so how do you grow your confidence to ensure that you're actually responding to their the complexity or the myriad of needs they might have? It's absolutely that we're screening and that we're asking questions that will give us some clues about performing and putting together a comprehensive care plan that responds to all their needs. And we're consulting and collaborating, not only with those clients, but with other healthcare providers. And we're always thinking about that continuity of care. What will happen prior to someone coming in to seeing us, and then after, if we're going to do a transfer of care, and what things have we put in place to ensure that that's as seamless as possible. As an organisation, there needs to be that very strong commitment and governance around any implementation process. And what that means is that implementation needs to be a whole of organisation approach, that it really needs to be supported by the leaders in that organisation, and absolutely that the staff need to be brought along on that journey. We heard both from Dylan and from Danielle about the importance of those meetings with staff, that there are champions within the leadership team of an organisation, even up to the board level, so that the board itself, all the way through to those that are working side by side with clients, they know what the goals are for this particular piece of implementation. They understand the importance of it. They can see the relevance and the significance of how it might really improve their own practice, and that we're bringing those clients, consumers, and the people that are reaching out for support on that journey with us. Really engaging some of those champions within that consumer section, that we're really ensuring that they're identified and involved, because they're often the ones that come up with some of these great ideas of how to implement a particular organisational change. And that we've actually started those partnership and linkages to other specialist services. Have we had a morning tea with a local mental health team? Do we know how we might escalate a particular issue if indeed someone needed further assistance? Have we reached out perhaps to a particular psychiatrist that could provide us some assessment support if required? Those relationships are the things that are really going to see you through. But if we don't have and do that preparatory groundwork with that commitment and governance within the organisation, then often implementation can fall down quite quickly. It's also then a good idea to really do a bit of an audit. So what are we already doing that's being really responsive to mental health and AOD needs? Maybe it's about looking to consulting with the people who are accessing the service. What do they think might have assisted them more or enhanced their experience of the treatment? We want to involve their families and communities. Were there things that we could have done a little bit better in order to ensure that they were well connected? We really need to bring everyone along on the journey, and certainly that can be worked quite well through those very solid quality improvement processes. And Danielle certainly mentioned that when she was having a bit of a chat to us. We want to take each program element. We want to look at the intake, that whole journey through our service. How is someone oriented to our service? What does our assessment look like? Are we actually asking some specific questions around someone's mental health needs? Is there something very specific in our care planning that is really perhaps takes into account maybe the interactions between certain illicit substances and the medication that a client might be taking? Do we have good medication management processes in place? And really, once again, that review of all those different elements, so that we're really keeping on top of each section or each part of the journey is really being mindful of both those mental health and AOD needs. And then it's about identifying projects of work. So rather than trying to do everything at once, it might have come to light through our auditing process that there are specific parts of the program or treatment that really need some particular attention, and that's where we should begin. So it's identifying some nice, discrete projects that have a bit of a beginning, middle and an end that we're able to then review as we go along. And certainly there'll be some interplay between these different projects, but it's really establishing that for each one there's a particularly well-described program, sort of logic. We're really clear about who the leads are on this particular project, who are the champions that are going to drive the work that's required. That there's a really clear communication plan, and so that everybody's kept in the loop. And certainly that we're identifying as we go along what are some of the capacity building projects that work alongside. Are the leads of these projects, or certainly staff members need some specific training, or perhaps it's some specific education or particular linkages? Do we need to perhaps recruit particular people with particular skill sets that might complement who we already have? Do we need to do a bit of a skills audit about where there might be some gaps? And absolutely identifying the feedback sources. So where's that data collection coming from? So here are just some steps that might support implementation. We've talked a little bit about those, and you would have heard those. Dylan certainly talked about the need in his example of implementing the Aboriginal healing framework, that actually that work was best done by Aboriginal people, of course. And what is the wisdom there that really could guide the changes that an organisation needs to make, and that's happening, and it shapes every part of every form, every recruitment process, for example, and you can see it woven throughout the program there. We've got some good flow charts and maps, so it's quite clear to everybody what their role is going to be and where they're ready to step in, and that there's a really clear data collection strategy. We know that implementation takes time, and Danielle certainly mentioned that, didn't she? We really need to take a step back. We need to have good timelines and really work very hard on the engagement process, because once staff and the organisation and the people who access the service are engaged, that will produce its own momentum. And really see the project come to life and really sustain the implementation process over time, so that over time it becomes common practice. And so it's really important to ensure that transparency is there, that people know what's happening, why it's happening. You're able to demonstrate to them the evidence, so that it's clearly evidence-based practice that you're implementing, and that they can see both from the person who's reaching out for that treatment and the person providing it that it actually works well. And so that's why you need those outcomes measures, that feedback from clients. Is this actually hitting the target that we need? And just lastly, I suppose it's really thinking about the resources that can support you. Of course, there is a wealth of resources on the Comorbidity Guidelines website. There's now Train the Trainer training that's occurred, so you can reach out for some face-to-face or online training. NADA has an enhanced performance management guide that goes through some really good steps, and I've referred to those as I've talked there. And CETA also has some guides around workforce development and organisational change, and there are some great tools for auditing your service in terms of how responsive it is to mental health and drug and alcohol co-occurring issues. I hope this has been really helpful for you today. Please feel free to reach out at any time, and I'm sure Matilda Centre will provide my details. Perhaps now, though, Chris, perhaps there are some questions that I can answer.
Always a challenge taking yourself off mute for me. Sorry about that. Thank you so much, Suzie, and thank you so much as well, Dylan and Danielle. That was fantastic. We don't have a lot of time for questions, but perhaps, Suzie, if I could just ask you for your top tips, seeing as you asked Dylan for his, I would be really interested to hear what they are.
Thanks, Chris. Yeah, certainly. I think the key thing really is to plan well. When there's big changes happening for your organisation, it can feel a little overwhelming. So I think the key thing is really to get the team together, have a look at your data. So what have you been collecting? What does it tell you? Talking to clients, how are we doing in the mental health or drug and alcohol space? Could we be doing something different or better? And then pulling people together to look at that information, that data, to inform some good planning, trying to segment it up so that you're not trying to deal with everything all at once. And certainly then starting to involve different groups into working groups so that you can see some of the achievements that are happening, and then to really make sure that you're reviewing those processes as you go, but making sure that you're not doing it on your own too.
Yeah, and you had some really important key messages throughout, I think, as well. Okay, so because also we are, I guess, rushing towards the end here, I have put your contact details on the screen there just in case anybody wants to get in touch with you. And before we do end, I wanted to quickly put up the resources of the co-occurring guidelines that you mentioned in case anyone wanted some more information about them. You can find out more information about those and other resources at our website. We also have the new Train the Trainer program that you spruiked for us. Thank you very much. And also thank you so much, everybody, for having joined this webinar. If you're interested in looking at the recording or any upcoming webinars, they could be viewed at the website there. And we have details of the upcoming ones on site as well. And thank you as well, Suzie, so much for having joined us, and as well, Danielle and Dylan. And please, everybody, enjoy the rest of your day and take care of yourselves and stay safe.
Thanks. Bye.
Thank you.